And I'd like to introduce Dr. Jim Karinji as our seminar organizer for this semester. Jim, the floor is all yours.
Thank you, Patrick. And while I have Patrick on the line here, I want to say thank you. He does a tremendous amount of things to organize this seminar for us behind the scenes. Very happy to welcome you to our Spring 2024 seminar series. This is a collaboration with the Academic Health Department at Montana Public Health. Dr. Damian Chase Begay and I have the pleasure of organizing these seminar presentations. So today we're really lucky to have Dr. Karma McKelvey, who is the Assistant Director for Research and Scholarly Activity and an Associate Professor of Public Health at Rocky Vista University. I also should have said that Stevie, the Border Collie behind me, is helping with running the seminar today, and I will ask her to be quiet in a moment. So thank you, Dr. McKelvey, for joining us. We really appreciate it.
It's my pleasure. And thank you for the invite. I mean, this is just the kind of group that I want to be part of. I didn't even know there was such a thing as Academic Department of Health. Hooray! So I feel like I'm among my peers, and I am I'm grateful for that because I spent the last 3 years. So who am I? My PhD is in public health, and my master's in public health is in biostatistics and epidemiology. Much better at the epidemiology part. And I spent a large, first 10 years of my career were tobacco control. I worked at Stanford School of Medicine and UCSF, the Center for Tobacco Control Research and Education in San Francisco. Made a hard pivot during COVID. I thought I was going to continue my work at Northwestern because we were living in Chicago. And, well, COVID had other things in store. So I worked in the Department of Orthopedic Surgery at Cedars-Sinai for the last 3 years. And very little of that research is in this PowerPoint. So if you ever need anything on patient-reported outcomes, let me know. That's what I did there. It's just not part of this presentation. And a lot of this stuff gets kind of granular. So if you feel like I'm glossing over it and you have a question, just let me know. And I'm happy to talk about any of this at any other time. So just by the pictures, these are Americans. Of course, we're kids. We don't have one, we have two. We think it's cool. We're on social media. And why nicotine arms race, that's the hookah and the vapes and the different kinds of cigarettes and tobacco control. And my animations don't seem to be, that's fine. So when I started this work, there were a bunch of unknowns. Did flavors in novel tobacco products affect youth perceptions of harm? I mean, of course, because the tobacco companies wouldn't have introduced them if they didn't, because the tobacco companies know from long years of addicting entire populations that the younger you get them, the longer you have them, and the more normalized the smell, not like something burning, maybe like cotton candy, one 15-year-old told me, their perception of harm just goes down. And how do these flavors affect drug use patterns in youth? Earlier initiation and more frequent use. Our tobacco companies, our tobaccos are, yes, both ours, they are targeting children, and our children know that. They say, no, these ads aren't for my parents. They're for me or my younger siblings. We have lots of recommendations on how FDA should handle the flavorings in hookah tobacco. And we were hopeful that the FDA would regulate the IQOS heat not burn products better than they did. And which measures of harm are most strongly associated with or predictive of health risk behavior in youth? That would be perceptions of general harm, and we'll speak to that. So I guest edited a special issue of addictive behaviors for novel tobacco products. And now here you see, it takes all this running you can do to keep in the same place. Just like what the Red Queen said to Alice, we're coming to realize we were talking tobacco endgame strategies, and here we are back at the beginning again. And a few ways, I have it written on notes, that we have failed to protect our youth in public health is we have allowed the creation of a tobacco product center within the FDA. And there's agreement among experts that the main reason it's still in place is because Philip Morris likes it there. It slows down our reaction time to new products. We messed up in public health by comparing e-cigarettes to cigarettes instead of fresh air. President Obama failed to ban menthol. That was awful. We allowed pre-market sales, purchase over the internet. I don't know about you, but if I wanted something when I was 18 and I had to be 21, I probably would have said I was 21 or clicked the button. Hookah circumvented clean indoor air legislation in many states and set us back. Again, we have to prove that tobacco is bad for your health. Juuls and stealth vapes, those stealth vaping, that all got in the works before we could blink. And just to please keep in mind, I will say vapes and I will say vaporizers, but that is aerosol. That is not vapor. So this is the conceptual model used by my PI at Stanford to get funding from NIH and FDA as a tobacco center of regulatory science. We had 2 cohorts. They started in 9th and we followed them till 12th grade, and they started in 12th grade and we followed them for 4 years to capture early to late adolescence and late adolescence to emerging adult. Now there we go. So what we're focusing on here is perceptions of harm that are very closely related to intentions to use. And then those are very strongly related to the behavior, which is basically the thing that we're interested in, is changing behaviors, health risk behaviors around tobacco. So the first look that I took was at the perceptions of youth in 2001 and in 2015. These are both cohorts assembled for the same reason by the same PI, and they asked very similar questions. And what we found was that more youth in 2015 declared less social acceptability and more harms associated with cigarette smoking. And the perceptions that changed most among youth were those that we as public health professionals and everyone in league with us presented the most and the most consistently. And so now in qualitative studies, our youth will tell us that if a friend offers you a cigarette, they're not a good friend. If they don't offer you weed, they're not a good friend. So we've gotten some progress, and we've also found that letting youth who don't think that they ingest tobacco but report smoking blunts, that they might just be tobacco users, and that can change their perceptions of the harm of the weed that they are ingesting. That's just a note. I was the co-chair of a measurement group inside of the Tobacco Centers of Regulatory Science, or TCORS. And what we did was we investigated prior regulations issued by FDA and how we could apply them, or how they should be revamped to address water pipe tobacco. And we came up with, we should ban all flavors because banning flavors is associated with a reduction in youth uptake. And if the flavor comes off the market, you can lose some of those youth users as well. If found to be more strongly predictive, conditional measures should replace general in national and other surveys. Years later, we found that they are not more strongly related. One question about the general harm of a product is as, if not more, predictive of behavior than some very granular questions. That said, the granular questions can be used to improve intervention design and targeting. But if we all agree on the measures, then we can generalize our studies. And I just put this in here. So we're changing the attitudes of adolescents who at one point may have thought that vaping or use of e-cigs was socially acceptable. We are reducing the acceptability of that with public health programming that lets people, first, youth don't like it that it is actually big tobacco. They thought it was not big tobacco. And they reported more often than not that there was no clear messaging that they could find. They couldn't find clear evidence to rely on about the harmfulness of vapes. But the tide is turning a bit, and that is why I think a child or a young adult won't start smoking, because not only do they know how bad it is for their health, the social norm has been changed and it is unacceptable. So if we need to kind of get there with the electronic cigarettes. So maybe the youth are changing their minds about e-cigs. Well, what about this product? What about this product that Philip Morris did have no warnings on, because to their mind, this was not a tobacco product because it is a dry leaf vaporizer. That said, what is that all the way over to the right? That's tobacco. It's tobacco packaged for use in this IQOS. I will say that it is a dry leaf vaporizer, and there is evidence that this is the least harmful way to ingest tobacco, or not necessarily nicotine, because the gum and the lozenges aren't that bad. But the vaporizers have glycerin-based juice that is toxic beyond the nicotine, whereas this is actually vapor, but their marketing claims. So the first one, and this gets granular and confusing, but that is the tobacco industry's reasoning for using it. They proffered these two claims. Scientific studies have shown that switching completely from conventional cigarettes to the IQOS system can reduce the risks of tobacco-related diseases. Fine. Scientific studies have shown that switching completely from cigarettes to the IQOS system significantly reduces your body's exposure to harmful or potentially harmful chemicals. Fine. The first is a reduced risk claim. The second is a reduced exposure claim. There's all sorts of problems with these, especially when we get to youth. For example, the control group, who saw just the IQOS product with no warning label, 58 out of 154 found them to be extremely, or thought them to be extremely harmful, whereas those exposed to the reduced risk, I have these numbers here too, were less likely to feel that they were quite or extremely harmful. And those with the reduced exposure claim, that has the biggest, with 45% of those exposed saying that it was quite or extremely dangerous to your health. So that reduced exposure claim is supposed to have nothing to do with risk. It's just supposed to tell you about reducing your exposure. And in the end, the FDA decided to allow the reduced exposure claim, which I'm sure Philip Morris lobbied for the strongest, because all of the evidence, ours first, that went to the FDA, showed that that is where their greatest benefit is. That's where they convinced the most potential users of its reduced risk, even though it's not a reduced risk claim. It's just so muddy. And same with the flavors, right? Oh no, these are for your parents. These are for adults who are smoking. These are better for them. Well, the way we investigated this was we showed the ads to young adults and adolescents, and they told us that, like, the vanilla and the Kona coffee, well, the coffee is for them or their older siblings or their parents. The appletini for the older siblings and parents, but the cherry and the vanilla, even though they're packaged very plainly, and they were shown these, said that they were for everybody, their younger siblings, themselves, their older siblings, and maybe even adults. But these ones with the pictures, none of those were seen as being for adults. The adolescents and the young adults told us that they thought those were even targeting their younger siblings and peers. So the popular flavors that are most strongly associated with uptake are menthol, fruit, and among adolescents and youth, they don't know because they don't care. Isn't it smells good? If their friends are doing it, that's fine. So it is important to regulate the flavors, and it's more important to just eliminate them because all of them entice youth. And with the packaging colors, this is just a poster. I don't expect anyone to be able to process this entire thing, but these packages over there to the left of the screen are the packages that we used, and along the bottom of the graphic there are possible attributes to be ascribed to the tobacco. Just to take a look at the concerning finding is that the mean age of these youth is still under the legal age for smoking back then, even though it's much younger now. But the smallest percent is a third, basically, that nailed it. The characteristics identified by the participants are exactly what the tobacco industries wanted. So it's just another call for plain packaging, which is another regulatory device that the FDA could use. Like that IQOS is sold in what looks like an Apple store, and it looks like an Apple device. But, you know, that's regulation for you. And the use and perceptions of pod-based electronic cigarettes. I'm going to apologize in advance for this next slide because I realized 5 minutes before logging in that there was nothing that explained our findings. And our findings were, the findings were, I'll come back, that the reason youth use vapes or choose one over the other is if it's easy to hide and buy. So if it's sold online, if they can palm it, less obvious vapor and smell because they're doing it at home and at school. And some of the schools in California have put vapor sensors, not real accurate, but they want more flavors. And if it's advertised as food grade, that means it shouldn't make you sick when you eat it, but it doesn't mean you should inhale it. Half the youth use certain vaporizers because they have more nicotine, and the other half because they have less. And the least often cited, but still cited, was to quit other tobacco. So kids are confused, unclear labeling. Initial studies of nicotine content were all over the place. None of the juice tested had the stated nicotine content in it. Could have more, could have less, could have none, could make people sick. And the effectiveness of tobacco control messaging and prevention interventions. Oh, I'm sorry. This part ties to what I was talking about, and then we'll go back to the things I skipped, which was how much nicotine do you think each product contains? We asked them about all of the products, and the proportion who didn't know was the highest for all of the vapes. As you can see, we had more Juul users than anything else. So when we asked just how much nicotine do Juuls have and gave them a different answer set, the same, more, or less nicotine in a package of vapes than in a pack of cigarettes, they were split. They didn't know. That's why they still use them. They don't know anything definitively. But what does this even mean? It's posted. What, 5% of what? 5% strength. And how much is 5%? Well, it turns out in a lab, we could tell that there was 59 milligrams per milliliter of nicotine in each little pod, the nicotine pod that you would change. And that is, each cigarette has about 12 milligrams per milliliter, but it's hard to compare. I just want you to be confused. And then this is what we went over. And so I have a haunted slide deck. It wants to animate and keep going at some points. I can't figure out how to take it out. Anyway, so takeaways are that the effectiveness of tobacco control messaging and prevention interventions, I mean, we should applaud. We should be happy. Public health made a difference. Kids aren't going to pick up a cigarette. I mean, those that vape, if they're hard pressed, they might, because nicotine withdrawal is very uncomfortable. And there is absolutely no evidence to support their use as a quit aid. What there is evidence for is that adult smokers who quit now vape and often go back to cigarettes, that adults trying to quit now smoke and vape, and it entices uptake among previously nicotine naive individuals. I'm showing you the conceptual model again because I'm going to move into very quickly measurement, which is, I love measurement. I love it. And back at the beginning, I said, which perception is most strongly predictive of behavior? And turns out that our results demonstrated that to better predict adolescents and young adult tobacco and marijuana use, measures that address general outcomes such as harmfulness, as well as willingness and behavioral intention should be used. So if you just ask, how hard do you think this product is? Or that will let you know, that informs their willingness to try the product. Only those who say that it's very harmful are less likely to initiate. So we were going to amp up the truth about how harmful these products are. And these findings indicate that measures of specific perceived social and health outcomes can be useful to discern nuanced differences in motivation for using different substances, but are not more predictive of behavior. And my PI at Stanford, she said, Karma, you will prove or disprove my life's work. And we pretty much disproved it, which is good for research in this area, because we had very long survey instruments, and the burden on participants was heavy and they were harder to generalize. So we ended up asking the very detailed questions as well as the general questions. And it's just a lot of extra work for not that much more benefit, unless you are looking at designing an intervention and you are trying to target a particular population. So this is what I'm working on. And if there's anybody in the audience who is interested or knows someone that could be interested and you have the bandwidth, we are formalizing a vaping intervention for adolescents. And again, I'm going to show you this slide because one of the behaviors we want is quit or reduce. And what we've found in qualitative interviews across California is that adolescents will not quit for themselves. I heard in more than one interview and focus group, in each interview and focus group, that adolescent, most of these were about 17, felt that they were the guinea pigs, that they had been caught up and they got into it before they knew, and they're not really that interested in quitting unless you drill down a bit and say, well, what about your younger siblings? Well, I would hate for them to be it. So could you be a model? And can we pair up at-risk youth who are already vaping and make them peer mentors for younger? So You and Me Together Vape Free is formerly the Stanford Tobacco Prevention Toolkit that I helped design. And we are, our intervention, we're thinking to call Be Vape Free for Me. And me could be your younger adolescents. It could be the earth, because jewel pods are everywhere. It's horrible. You can get at their inner motivations through outside avenues, is what we're learning. And these are just examples of what we've done. We drive a van around. We have these websites. You guys can access these. Teach Vape Free is for educators, and Live Vape Free is for students. We have a BMX freestylers, that's tobacco prevention. The little kids, we have the Busy Bee, and Music Notes are a couple of musicians who travel around and present a tobacco prevention and harm reduction programming. And then we have professionals come and speak to at-risk kids, to our partners in tobacco prevention, and our parents. And that is it for me.
Thank you very much, Dr. McKelvey. This is such an important topic, worldwide, really, but, certainly in the communities around the University of Montana and here in the state. So we have time for questions. So if folks would like to unmute and ask a question of Dr. McKelvey, I know she would welcome that. Or you also can put them into the chat. And I did hear Dr. McKelvey welcoming ideas for collaboration. So that would be really great to hear if there are any there too. So questions?
I can give you a quick update on that IQOS product. The FDA, in all their wisdom, put that reduced exposure claim on it. And it went gangbusters for about a year, but then they had to stop selling because of a patent infringement. Not for the health of the public or anything, but because they were getting sued for patent infringement. So we can keep our fingers crossed that it'll stay off the market. But I was traveling internationally, and it is everywhere else.
Hey, thank you, Dr. McKelvey. We have a question from Chris. So the Stanford Tobacco Prevention Toolkit will now be called Be Vape Free, etc.
It is now called Together. Oh, shoot. Together Vape. You and Me Together Vape Free. Yes. You and Me, together, vape free. Yes.
Excellent. Thank you. I have a question. So, we have different cultural groups here in Montana and the Rocky Mountain West, and there certainly are vaping issues in some of those communities. And I'm curious, Dr. McKelvey, if there have been any cultural adaptations that you know of to any of the approaches to decreasing use or prevention.
I know at Stanford, we tailored it for Spanish speakers, and I believe that's it. But what they've also done is they presented in Hawaii, and then the Hawaii Department of Public Health they're working in partnership. And that's what I would like to do, is bring it to the native populations. And I would like to work with the native populations. RVU is located basically on the Crow Reservation next to the Shivwits in Utah, and several tribes in Colorado. So I would like to assess the vaping there and then tailor the education and the intervention. I'm interested in an intervention, whereas the Together, You and Me Together Vape Free is education.
Thank you. We have another question in the chat from Chris. Are you finding more schools are utilizing the Healthy Futures alternatives to suspension programs?
Yes. And I can only speak for the school districts that I work with in California. And that is the Healthy Futures is also being used as an alternative to suspension and as part of a comprehensive tobacco use prevention and education program that has, say, the things from You and Me Together Vape Free, as well as positive youth development and alternatives to suspension. So short answer, yes, but I rarely give a short answer. Sorry.
Hi, Carmen. Thanks for your presentation. Quick question about the question about rural versus urban. Do you like how pervasive is vaping among kids in rural areas compared to more urban areas, and more specifically to Montana?
Yeah, and my house flooded a few weeks ago, and those slides that I was going to prepare, I didn't do the research. I can tell you in California that vaping was more prevalent on rural, among rural kids with like their parents' credit card, and less. We had to pay adolescents at least $100 to get them to participate in our surveys in San Francisco and urban Los Angeles because they don't care about money. And so they buy them and they use them and they share them and they sell them to younger kids. Whereas rural populations were more using snuff and chew. So it divides along socioeconomic and rural urban, like basically every health thing in the United States. Of course, they're cheaper now, so I'm assuming that it's going to spread.
Thank you. Dr. Goldstein-Cole has a question. In the past, there were strong associations between tobacco initiation and the use and later substance use disorder. What, if anything, do we know about vaping and other substance use among adolescents?
So it is indicative of, it's associated with younger age at uptake, which is also associated with later use, increased frequency and intensity of use across the life course. But it's also been strongly associated with a group that we named experimenters. I did a latent class analysis among vape users, and the more they vaped, the more likely they were to try other products, but they were not, and granted it was a constraint of 4 years, they were not more likely to have continued use. So the scariest thing for me with the flavored vapes is that it's younger use of initiation, and it's an increased willingness to try more things. But my familiarity does not extend to these like last 4 years. And so I don't know if now we can associate it with longer continued use of tobacco and other drugs.
Thank you. Other questions? Go ahead, Sarah.
Sorry, didn't mean to.
Oh, no problem. Any other questions? Okay, well, we really appreciate you coming to present, Dr. McKelvey. Look forward to hearing more about your work in the future. We will end a little early, and now, you know, if Zoom these days, we can yield back some time. That's probably good. I know that I've been going since 9, so we hope to see you in person here in Missoula sometime. Next week, we have another seminar series presentation happening, which will be about vector-borne disease and trends in Montana, specifically, I believe, around ticks and Lyme disease. So it might not, that will be Devin Kozart. So it might not seem like we need to worry about ticks at this point. It's been so cold, but believe it or not, there'll be, I understand from a pal of mine, Dan Dructra, who does research here, they're at it earlier and earlier. So this will be another presentation that will be really impactful for us in our communities here in Montana and the Rocky Mountain West. So thank you very much for coming, everybody, and we hope to see you next week.
And please, anybody and everybody reach out to me if you want to do any sort of tobacco control interventions, because I would love to participate and I have a lot of students who would too.
Awesome. Thank you, Dr. McKelvey.
Thank you.